I'm waiting for the live to pop up on my VBF. Let's see, it's not here yet, but it will pop up when this line turns red. Oh, looks like we might be live. It's Dr. Linda of the Vascular Birthmarks Foundation coming to you live from New York City. This is our very first Facebook Live with Dr. Joseph Panarelli, ophthalmologist from NYU, and very knowledgeable about not only Sturge-Weber glaucoma, but also like choroidal hemangiomas and other lesions that are often associated with vascular lesions and vascular anomalies. And today, all things are about vascular lesions and the orbit. I'm just going to check for a second and make sure that I'm live. There we go. See, I see the red thing there, so I should see us on here. And there we are. Great, great, great. So let me just, get this back. There we go. So I can see when the questions come in. Here we go. All right, so those of you who are on, hi, Kiana. Kiana is on from, I don't see, it says you're on, Kiana, but I'm not seeing it on my questions on here. Oh, there it is. Okay, I see it. So now I know my questions will show up. So Kiana just asked us a question, so I know that everything is working. So Kiana is our director of our Global Ambassador Program. And for everyone that is waiting to log on, hi Shadi, there you are from Idaho. Happy to see you, Shandi. Welcome, welcome. And anytime you can ask questions, I'm just getting organized today. So it's our first time doing lesions of the orbit, and you'll ask the questions directly. I'll read them for Dr. Panarelli and he will answer. I see that people are jumping on now. Hello, Liam, how are you? And at any time you can start with your questions for Dr. Panarelli. Also, he will be with us in another month at our clinic in New York City. We'll be at the Laser and Skin Surgery Center at 317 East 34th Street for the clinic on Saturday, and we will also be doing ultrasounds and glaucoma checks on Friday, and Dr. Panarelli will be speaking on Friday afternoon. So if you are coming, you're going to have a lot of opportunities to learn a lot about orbit lesions. And if you're not coming, we still have some openings. So go to our website at birthmark.org and scroll down until you see the New York conference. I see we have other people logged on now. So again, at any time, you can ask your question of Dr. Panarelli. So Kristen has a question, and it is, how do we know when to have surgery? How do we know what kind of surgery to have? Should we have a SWS specialist or an ophthalmologist is fine? And I'm assuming it's for glaucoma or eye problem.
All right, so that's, it's a great question to get us kind of started here. So I will say that I think glaucoma is often associated with various different vascular anomalies that are around the eye, and most commonly we see when there's a lesion that affects the upper lid. A lot of times that's a tip-off that there is potentially something going on inside the eye, and the glaucoma can come about for a variety of reasons, and a lot of times the biggest question is not so much exactly what surgery to do, but when to have surgery. And I would say that if you talked to me a long time ago, back when I started my training versus where I am now, I would say that my answer to that question really has changed a lot over time, in that I think historically we probably operated more for this condition maybe than we maybe wanted to, and that was because we felt very unsettled with some of the pressure measurements we get on children with Sturge-Weber and other vascular anomalies. And what we learned over the years is that these children tend to live at higher intraocular pressure, and that pressure does not always need to measure up and be similar to the opposite eye. And so I think you have to be a little bit more comfortable with the uncertainty, and I think that is the challenge. And so, a lot of times what we do is we look for a few things on the examination. We look to see if the pressure in the eye is causing damage to the optic nerve. If the optic nerve is sustaining damage, or if in a young child the eye is starting to grow too quickly because the pressure in the eye is too high, those are reasons to get in there and do something surgically. And a lot of times the surgery involves opening up the natural drain in the eye, or putting in a new outflow system, so a tube to control the pressure. So it's a long answer to maybe a short question, but it's really something where the type of surgery really depends upon the individual case that we're being presented with.
Yeah, that is an excellent answer, and it gives a lot of descriptions for all the people that are logging on now. And once again, Dr. Panarelli is an ophthalmologist and expert from NYU in glaucoma and other eye issues associated with vascular anomalies and vascular birthmarks. I think it's very interesting what you just said, while we're waiting for our next question, that kids kind of stabilize themselves, don't they? So you're saying if the normal range is what? What is the normal range?
It's about 10 to 20 millimeters of mercury is the normal pressure in the eye.
So if one's around 30, you're not going to now, or...
So that's where it gets tricky.
Okay.
So again, 10 to 21 is the normal range typically for an adult population, all right? And so we don't have a lot of data on children, let alone children who have vascular anomalies. So really, we're extrapolating what is a normal pressure for an adult and saying that that's what it should be for this child. And in truth, maybe a pressure of 26 is okay for that child. Maybe a pressure of 18 is okay. Typically, a pressure that once you get above 30, I will tell you that I don't think that is ever physiologic. So to me, a pressure above 30 in anyone is always an elevated pressure, and that is likely going to lead to damage to the eye. And again, the damage in children can come in different forms. I take care of both adults and children. In an adult, the elevated pressures will cause damage to the optic nerve. In a child, the elevated pressures can do one of a few things. It can cause damage to the nerve, which is obviously not good. It can cause the eye to grow too fast. Children's eyes are very elastic, so if one eye is starting to grow and get too big, the brain will preferentially use the smaller eye, and that other eye will never develop good vision.
Is that like astigmatism?
They call it amblyopia.
Or amblyopia.
Amblyopia. So amblyopia is actually the bigger enemy of the glaucoma specialist than the optic nerve damage. The final thing that can happen is when the pressure in the eye builds up, you can get breaks in the front of the eye, and you can get astigmatism and swelling of the cornea from these changes. And so there's a variety of things that can happen when the pressure in the eye is too high in a young child who has a vascular anomaly. But the question is, as you said, is that pressure too high? Now just we'll take it, I know we have an audience here that's very educated, so I'll take it to the next level. The challenge is, for children who have vascular anomalies, the pressure in the eye is often elevated just from the start because their floor pressure is just higher, because there's a pressure in that venous system that keeps them at a higher level than what, say, the average pressure should be. So it's that delta that we don't really understand. So when you compare a child who has a vascular anomaly on one side and not on the other, that eye that has the vascular anomaly is always going to live at a higher pressure. The question is that higher pressure too high for that optic nerve? And
it's almost like an adaptation, right?
Correct.
Right. So
Correct.
if it's born, and they are usually born, some of them are, some of them.
They've been living at this elevated pressure. Their floor in that venous system is higher than what the floor is in the other eye. So yes, the asymmetry will look extreme, and you'll say, "Whoa, this eye is 8 points higher than the other eye." Well, it may just be used to living 8 points higher than the other eye. And so the question often when I see a child is, has there been a change in the examination? Has there been some change in the size of the eye, the appearance of the eye, or of the optic nerve? If one of those three things, if the answer is yes, then yes, we need to go ahead and treat. And we need to treat either with drops or a lot of times with surgery.
And when you talk about the size, you're talking the globe.
The globe,
because the
yes.
globe
So
we've seen some babies born with Sturge Weber that have an enlarged globe.
Correct. So a lot of times I will have a child brought in between 1 and 3 months of age, and the first thing I do, I take a look at the eyes. I forget about trying to get in there and measure anything, and I just look. And the person who's going to give me the most information is often the parent. And that parent is going to know, and we're going to look at pictures, and we're going to see if there's a disparity in the size of the eye. If one eye is bigger, then that is something that sort of sets off some alarm bells in my head, and we have to consider doing something.
Awesome. So Kristen says, do you feel like the answers are different when we're dealing with children versus adults? You kind of answered that. Or?
Yes, so definitely. So I think when there are vascular anomalies, vascular lesions, glaucoma can come in a few forms. So kids can be born with a glaucoma that's very similar to our primary congenital glaucoma, where the drain in the eye doesn't develop. That is actually one of the more treatable conditions, in that we can do our usual surgery and we can fix the problem. It is a little bit trickier in that late first decade, second decade of life, where the pressure in the venous system continues to rise, and we get more of a chronic glaucoma that's a little harder to control. So there's really, to me, there's the congenital side, which is typically the first year of life, and then that late first decade into the second decade, which behaves a little more like the adult form. And really, I hesitate to even say there's an adult form, but it is a condition that we continue to treat, decades, into the future.
Shandi has a question. Are you most concerned about checking for glaucoma with the port wine if it's covering the upper eyelid, both upper eyelids? Is there something you can visually see with the eyes that would cause concern for glaucoma?
Really great question. Definitely, if we see that the vascular anomaly is involving the upper lid, we do have a heightened concern for glaucoma. If it is bilateral, yes, definitely. So definitely the size of the eye. So definitely, if there is a lesion on one side and that eye looks larger, 100% there needs to be an evaluation for glaucoma. So again, certain times children's eyes can be a little bit larger for a variety of reasons. Sometimes it's the cornea, sometimes they're nearsighted, but anytime you see asymmetry, especially in the face of a vascular lesion on that side, and I think, as you pointed out, sometimes even the appearance of
the pinching.
The pinching, that you call, but there's clearly some asymmetry. You have to evaluate for glaucoma.
Excellent. Lacey says, this is interesting. My non-port wine stained child has multiple birthmarks and her left eye has many gray spots. Should she be seen?
So typically there can be different forms, and I would say, Linda, you probably know more about this than I do in terms of all the different variants of vascular lesions. You can have nevus of Oda, you can have different appearances to the sclera. I think we are fortunate in New York to have so many specialists. I work with a lot of our great ocular oncologists at Memorial Sloan Kettering, so I often have Jasmine Francis always take a look whenever I see something that I don't routinely see. So I would say yes, if nothing else, then that later on in life, if you have photographic documentation of what something looks like in a child, it maybe gives you less concern when somebody looks at it later and may see a change or not. So I would say that I think, yes, it is reasonable to at least get photographs, document it in the contralateral eye, even if this is the eye that does not have the port wine stain.
Thank you. Jessica says, my daughter has Sturge-Weber, and when we did her MRI, it shows glaucoma in her left eye only. No right side involvement. When we did her pressure checks 1 month later, her right side had higher pressure all of a sudden, 20, and then 20/25 pressure read. Would you trust this pressure read?
That's the challenge, especially in checking pressures in children and young adults. It's very nuanced. It's not so easy. You get a little, you tense up a little bit and you get some artificially elevated readings. Sometimes it's the person who checks a device. Sometimes it is just a difference in the reading. There can be, as I said, a lot of movement of the pressures. You can check pressure in the morning and it can be very different from the afternoon versus the evening. Monday is different from Thursday. I would say that numbers in that 20 to 30 range, it's okay, especially if it is asymmetric. I'm still okay with it. I think for me, it's looking at, again, all the parameters. It's looking at the optic nerve, looking at the pressure, and put all the pieces together. It's hard to take an isolated pressure reading and sort of say, yes, this is something to be worried about, or no, this is not something to be worried about. Overall, I wouldn't worry. Pressure numbers are going to move around, especially in that 20 to 30 range in a child, and I think it's okay. But I do think the full exam needs to be performed.
One of the things I learned from one of your favorite patients, Chiara, and her mom pointed it out to me, that when she would get her laser treatment and the ocular shield would be used, she'd then come and see you, and the pressure would be artificially, temporarily elevated from the pressure of the ocular shield.
So definitely, if I checked your pressure, Dr. Linda, just sitting here right now, and you held your breath, or you bared down for a few minutes, we could definitely get a pretty good discrepancy in the pressure readings. In somebody who has a vascular lesion on that side, that change can be even more dramatic. And it is because, again, the pressure in that venous system. And so there's a lot of things that can cause the pressure readings to be a little bit variable during a clinic visit. And yes, I think actually even having treatments, laser treatments around the eye, where you're increasing some congestion in the venous system and you check the pressure shortly thereafter, you can get some temporary spikes in the pressure. So I think there's a lot of factors. But again, that goes back to the point where you can't solely be looking at the pressure in the eye. You have to honestly sometimes do an exam under anesthesia. You have to be able to do good exams in the office. You have to be able to get more of that information, and you can't solely rely on the pressure, because if you do, I think you're going to unnecessarily treat a lot of children with medications or even surgery. And surgery, which I'm sure we'll get to sometime in the next hour, carries significant risk in this patient population. It is probably the riskiest surgery of all the glaucoma surgery that I perform.
Wow. Important stuff. So Natia says, apology if this was already mentioned, what is a typical age glaucoma is detected, and at what age would you say the chances of it developing are unlikely? Can port wine stain pressure lead to migraines? Yes, I can answer that one via Dr. Comey, our Sturge-Weber syndrome neurologist, who's always asking, does the patient have headaches? And if the patient has had imaging done, I suggest you go back to the neurologist or go through our website and ask Dr. Comey herself, because headaches can be related. Now, back to you on the typical age.
Great question. Like I said, typically there's a few sort of variants of glaucoma in children who have vascular anomalies. There is the congenital form, which typically presents within the first year of life. I find that is fairly common. A lot of times, if you get through the first year and not much is going on with the pressure, we're often pretty good. Now, the challenge sometimes is, though, we're still going to, if you check for it, you're going to get some asymmetry of the pressure. And the question there is, are we going to end up over-treating because we want to be extra careful? And a lot of times we do. I tend to feel a lot of times, once I'm past age 3, I'm pretty good until I get to that late first decade where I'm closer to that 10 to 15 years of age. I also think puberty.
Yes.
I think puberty causes a change.
We know that.
And I think, again, the hard part here is we don't have enough data. We don't have enough science. We don't have enough literature. A lot of what I'm telling you is just anecdotal evidence from treating a lot of children with this condition and seeing a lot of it firsthand. I do think now, again, is it the disease picking up? Is it a change in the outflow system of the eye? Is it just puberty and a change in the hormone levels? Maybe it's a variety of those. But I do get a little more concerned in that 10 to 20 years of age, where I sometimes see a spike in the pressures during that point. But again, I've seen people where the pressures have picked up in their 30s, their 40s, their 60s. So I can't quite say that we're out of the woods at a certain point in time, but I will say that those are sort of the periods where I'm a little bit more concerned. The question, though, about headache is actually very interesting, because I do find that when children have choroidal hemangiomas, so they have vascular birthmarks in the back of the eye, if there are some changes in the pressure inside the eye, they will feel that expand and contract. And I have found that some of my patients who have had surgery complain of some really intense pain after, and I do think it has to do with sort of the expansion and contraction maybe of the vascular lesion.
Very interesting. Which is why it's great you're joining our team, and you'll be at the clinic and conference with Dr. Comey.
It'd be great to talk.
With her together, the two experts with the neurologist.
And I'll tell you, a lot of what I've learned has been from listening to the patients. I've had some wonderful patients who have taught me so much more than I've ever read in a textbook from their experience. And so in just listening to what they tell me, I've learned so much more.
So Gracia is saying her son is 3 months old, has a port wine around the orbit. Do I need to take him to get an eye exam?
I would have 100% say yes. I think at least start now. Again, if you said, hey, do I have to get to a pediatric glaucoma specialist right away? I would say I think we can pump the brakes on that. But 100%, I think it's worth seeing a pediatric ophthalmologist who can check the prescription in the eyes, who can check the size of the eyes, who can just look for some basic findings. I don't think you have to go rushing to do a full exam under anesthesia in the operating room, but the pediatric ophthalmologist a lot of times can assess and at least see where we're at. So 100%, I think it's worth it.
Get an assessment,
100%.
a simple office assessment.
Correct.
That's excellent. This is a good question about adults. As an adult, should we just give up and let it take its course in one eye? Like, is there an age where surgery is so risky that we just shouldn't do it?
It's a very thoughtful question, and I pause there because I've battled some really tough cases where I've asked myself, should I have just let the disease run its course and seen what might have happened? Did I speed up the rate of vision loss? And that is never, ever what you want to be responsible for as a doctor. Our job is always to keep you out of harm's way.
Spare
to
the
do no
sight.
harm.
Yeah,
That's just what
no
we
harm.
do.
Yep.
That being said, I think the important thing is to always talk to the patient and understand that, especially with this condition, and this is actually true of all glaucoma, that sometimes you will lose some battles in winning the war. And that is what might happen. There may be a loss of vision, but in the end, we will stabilize it. I think if the pressure is elevated to a point where it appears that that optic nerve will not be able to hold up over time, surgery is definitely the way to go, even with whatever you have to battle. I do think so, because I do think my conversation I have with patients is always the same. I recommend surgery when the risk of observation is greater than the risks of surgery. So if the risk of doing nothing is blindness, then yes, we have to do it. And though I have said that yes, this is some of the most complicated and risky surgery, we get through it. We battle it. And we all battle it together. And I have plenty of patients where I think I saw one patient, bilateral case, Megan, one of my dear patients, I saw her, I think, and her dad, they drove hours every single day for like months, I feel like. I mean, we are like family at this point. I mean, the amount of time. So, while it is challenging, and while sometimes you can sometimes feel like you did not get what you want, in that, again, what we often always want is we want to keep the same vision and fix the problem. We will get there. And so, it is a fantastic question. It's a very thought-provoking question because, again, for me, I sit here and have to sort of answer that and sort of say, what is the risk benefit and what is it for the patient? Now, again, it depends on the adult, it depends on the age and everything, but most of the time, this is a condition that is affecting patients who are younger. So even the adults, they are typically younger adults. They're 30, they're 40, and that is a big question to have. And
so is the goal to protect the optic nerve from damage?
Different goals at different points. In the
Okay.
child who is 0 to 3 years of age, we're trying to slow down the growth of the eye and prevent the eye from developing any breaks in the front that will lead to amblyopia, where the brain
Okay.
won't be able to develop good vision. That is more of the goal there. In the adult population or even the adolescent population, yes, we're looking to protect the optic nerve.
Awesome to understand that. Chelsea Nipper says, if a child has been diagnosed with congenital glaucoma and she is almost 2, for the first time ever got a pressure between 30 to 34 in her eye, the other was around 15, the doctor recommends rechecking in 4 weeks. However, if pressure is still up, recommending an additional drop. She is already on morning and night. What are your thoughts?
So, when I came back to New York, I trained in Miami, and I did a few months. I had a great mentor who taught me pediatric glaucoma. All of a sudden, I was a specialist. There's not a lot of us around who do children's glaucoma. And so, I'll admit, early on, I tried to be conservative because I was very young, and I think that's what we should always start off. We should, but in truth, unfortunately, a lot of children's glaucoma, especially congenital glaucoma, it is not responsive to medical therapy. It is often a surgical disease. The medicines are often a temporary fix. You often have to open up the outflow system because it never developed properly. That is how congenital glaucoma behaves. It is different from adult glaucoma.
Because the vessels narrowed?
The drain, there was a hiccup in the embryology, and one of the membranes that needed to cleave never cleaved. And so there's really an obstruction to outflow in the eye. And so really the fix for that is mechanical. You have to incise that drain, or you have to get into the canal and open it up. The medicines really, think of it just like a sink. The medicines are trying to shut off how much water the eye is making, but really the problem is outflow, and we have to reestablish the outflow. So in this situation, if the pressure is going up to 34 and you're already on multiple agents, I don't think the long-term solution is going to be another drop. It is likely going to be surgical intervention. Again, it's not 100%, and I don't want to sound overly aggressive, but true congenital glaucoma, whether it's associated with a vascular anomaly or it's just straight primary congenital glaucoma, surgery is the treatment. Needs to be done by somebody who's trained in it, who does it well, but surgery in those patient populations is 90-95% effective.
Thank you for that. That's a good answer, Chelsea. Thank you for writing that question in. It was a good one. She said this is her first time her pressure has ever been over 23.
Again, there can be situations in an office where the pressure is elevated because of certain conditions, if the child is upset, uncomfortable. So it's always worth a recheck. And again, you could always have a one-off, but I would say that, again, you have to put the whole picture together. If the optic nerve looks different, if the pressure continues to be elevated here and there, sometimes have to do something about it. Again, it is challenging, but it's, again, putting the whole piece together. But I would say that a lot of times if you get elevated readings in children, especially when it's asymmetric, you have to be very suspicious and very careful with them.
Great answer. Abby has a question. What is the likelihood of glaucoma developing if the port line is around the eye on the cheek, below the eye, up the bridge of the nose, and in the eyebrow, but does not touch the eyelid itself? Is the concern for the glaucoma the same if it doesn't touch the eyelid?
I definitely think we know that there is a greater association when it does touch the eyelid. I don't think I can say I definitely have had children I've taken care of who have vascular lesions that are not on the eyelid and still have an issue with the outflow system. So I can't, again, the challenge is to give an answer to that, and I'd love to, I want to, I just don't know. We don't have enough, and this is where you are wonderful in all the work you're doing with getting more databases, getting more information, where we do need more data, more information so that we can answer questions like this. Because in truth, I don't know. I can tell you that, yes, I've seen it, it is not as common, but I can't say that it's, of course, a 0% chance, but I can't say it's a 50% chance. I just don't know.
This would be a great study to
Great.
collect this data, and I'm more than happy to do it. This is interesting because Chelsea said we know that her drain is abnormal, and the pediatric specialist in Miami
That's where I train. That's my.
said hold off on surgery due to the risk with the vascular system.
I listen, I would trust them, whether it's Dr. Chang or any of the wonderful doctors down there. They know what they're doing.
Okay, so Zaradi has a question. I have a 5-year-old son with Sturge-Weber epilepsy and glaucoma. He has a hemangioma in the orbit, likely choroidal, right? He has had 2 trabeculectomies,
Okay.
trabeculectomies, and 2 CPCs. Shunt is not recommended because of the place and the size of the hemangioma. We use 2 eye drops, but the inner eye pressure doesn't go below 30. Can another CPC bring a long-lasting result? What can be the outcome of the high pressure? How fast can sight loss happen? Can sight loss go together with pain in the eye or with hemorrhage? It's a lot.
It's a lot, but I have seen lots of cases like this, and I totally understand. So, 4 surgeries already is challenging because it makes that next surgery even harder to get surgical success. I often say our first or second chances are our best shots, but again, I've had plenty of times where I've gotten in there my 3rd, 4th, or 5th time and I've been able to get it. The key is to just, you got to hang in there, and it sounds like they very much are. Trabeculectomy is a really, really hard surgery to perform in an adult, and it's even harder to perform in a child because of the child's robust healing response. And this surgery
I was
is really...
going to ask if it's scarring.
It's scarring.
It
So the
is
trabeculectomy is scarring, and that's
Yeah.
what happens. I would say that trabeculectomy is hard to do in an adult, hard to do in a child, and even harder to do in this particular situation. And so a lot of times we'll open up the angle, we'll do a trabeculotomy with a trabeculectomy, we'll try to open the drain up. CPC is where we're trying, again, we talked about trying to shut off the production of fluid in the eye, so turning off the faucet. And essentially it's a laser procedure where you heat up the muscle of the eye and you try to basically destroy parts of it so the eye doesn't make as much fluid. Not an easy procedure to titrate, and especially hard to titrate in a child. And depending upon the size of the eye, it's often hard to find exactly where to treat and to do it well. My answer, having trained in Miami and just having done tons of these, would have been to put in a shunt. But it sounds like if there's concern about placement, depending upon what's going on in the orbit, that may be an issue. I don't know who's following the child. It's hard to say that. I almost always can find a place to put a shunt, but maybe there really is, and there's 4 different quadrants we can work in. A shunt is typically what I'd want to do in this situation, and I'd have to find a way. Maybe I work with my ocular oncologist to debulk whatever's around or to figure out some way, but to me, the more recalcitrant the case, the more likely I am to put a shunt in that eye. And maybe, and again, I don't know the situation fully, I'd get another opinion just to make sure that is clearly the case, that you can't put a shunt there, because I gotta be honest, I haven't found too many situations where I can't. And sometimes we have to be a little bit creative and figure out how we get this done. I've done it with children with neurofibromatosis where they've said, oh, there's too much in the orbit, we can't do this. And we figure out a way to get it done. I would say a third cyclophotocoagulation, a third CPC is going to be really hard to titrate that. Vision loss, I don't know how long, a pressure of 30, as we talked about earlier. You'd be surprised at sometimes how a child with a vascular birthmark can actually tolerate a pressure 25 to 30 for quite a long period of time. I don't know. And that is where, again, having a little more history and understanding where you've been. But again, as I alluded to earlier, I don't love seeing pressures live in the 30s. That is of concern to me.
Well, this other mom is kind of following up on what Chelsea had just asked you, and she said, you know, what should we do if we feel like the ophthalmologist is advising against surgery, but the numbers keep being up there? Is that when you go for another opinion?
We as surgeons who treat this condition need to have a healthy amount of, we need to be aware of the risks, but we can't be scared of the risks. And I think that is a challenge. I tell that to all my trainees, you can't be, you have to sometimes forget that last not great outcome, though it has to still be there in your mind, because not every time you tackle a tough case are you going to always have one of the more challenging complications. You can have them, but you know we have to be able to deal with these complications and challenges. 100%, whether it's somebody who's seeing me or a colleague, I will tell them if you don't feel that recommendation is if you don't feel comfortable with it, 100% get a third opinion. 110% get another evaluation. I suggest that to my own patients. I tell them, I will sometimes look at a patient and I will see, we're just not seeing eye to eye. And I will say, listen, I'm not offended. Please go get another opinion. Because my opinion is not, it's just my opinion.
And I tell every parent to trust their instincts.
Trust your instincts.
Trust their instincts.
100%. Now that being said, there sometimes is a point where sometimes you want to hear something that you're just not hearing. And, you know, there are definitely some times where we do have to be careful with what we're doing. But I do think if there's clearly a situation where a child is losing vision because of the pressure being too high in the eye, yes, you have to get the right opinion from the right person who's willing to tackle the tough case, if that is the case.
Chelsea, I don't know if you're coming to our conference, but Dr. Panarelli will be there. She wants to know if you perform the drain surgery yourself, because they don't know anyone outside of like Miami, and they said, referring back to Bascom Palmer, is that a place or?
Yeah, that's where I trained.
Oh, Bascom
Yeah,
Palmer.
I used to work there too.
Okay.
So I trained at Bascom Palmer. So Bascom Palmer is a wonderful, it's one of the best eye hospitals in the world. They have, that's where I learned how to do
Dr.
pediatric
Chang
work.
is
Yeah,
there.
that's what I was saying before. Peter Chang is, Peter is wonderful. Honestly, I whatever Peter says, I would probably say to do. It's hard. There's, and you'll see one of the things that is great, but at the same time is sometimes not is not great. Is the fact that we don't always agree, all of us, and so it is wonderful to see there's a healthy amount of debate in how to do things, and we challenge each other and we push each other. But at the same time, I understand as a parent, as a caretaker for some of my older patients in my family, I don't love when doctors have two different opinions. I'm kind of like, who's right here, who's wrong here? It's challenging because, again, we all will go at things in a little bit of a different way because we have different experiences, and maybe in our hands something works better than something else. And so I think that is a bit of a challenge, but I do think no matter where you go, whether you go to the Bascom Palmers, the Wills, the Wilmer, NYU, it's okay to get another opinion, and it's okay to sort of to see what goes on, because maybe in somebody else's hands they can do something different, and maybe they have a different team. So
We
it's hard to
say the same thing all the time for laser treatments. You know, go get a couple test spots by different doctors, and you know, trust.
Okay, so I'm the patient, not the mom. Okay.
Yeah, so I wanted to tell you
Okay.
that she did say she was the patient, not the mother. She's 56, and she was the one who said, let me see what she said. Okay, that was the one
So
advising against.
I
the
would not
surgery.
give up, and I think a lot of times, you know, even in tough situations, a tube can be put in the eye, even when maybe sometimes it seems like maybe there isn't enough real estate or enough room to work. Again, I don't know that's 100% the case, but for the most part, you know, we can figure things out.
Is there anything new in glaucoma? I mean, we are seeing a lot of new things happening with HIFU, high intensity focused ultrasound. Are there any new things right now being discussed that can address behind the orbit, you know, in a non-invasive way?
So, again, a lot of it comes down to the mechanism for what is going on here, what is leading to the glaucoma. So a few things. So just starting off with even just the diagnosis, making the diagnosis. We have better tools for checking pressure in the office. And again, sometimes we do get some erroneously high measurements, but we can actually check kids in the office now as opposed to having to take them always to the OR to go to sleep, which is a big concern for a lot of parents, and I understand that as a parent,
Yeah.
the risks of anesthesia. So we've had advances in our ability to pick up glaucoma. We've had improvements in our ability to monitor it, so our imaging of the optic nerve. Now again, a lot of the imaging for the optic nerve was designed for adults, but many of us will use them in children, and we can sometimes track the optic nerve a little better and look for signs of change, so we can sort of better decide when we need to get more aggressive with our surgical treatment.
Is that a CT?
OCT.
OCT.
So OCT. Again, it's a little hard to do in kids because, again, there's not a lot of normative databases, but we do it, and we are starting to compile more data. In terms of surgery, yes, there are definitely surgeries on the horizon and more new devices and different things, and we're getting there because the challenge here with when we have a vascular lesion, we need to be able to lower the pressure, but not lower it too much. It's like landing a plane. You don't want to come down too quickly, especially with port wine stains, Sturge-Weber. What we're trying to do is we're trying to come down in a controlled manner. It is often that dramatic change in the pressure that leads to the expansion of the hemangioma, and then it leads to fluid that builds up behind the retina and behind the eye. And that's what leads to some of the challenges that we have. That is very different from what we see in adults when we drop the pressure. We don't see as dramatic of a response.
Yes, time flies, just under 30 minutes left to ask your questions now. Thank you, Kiana. That's true. We've had such a flurry of questions. So when you come to the conference, you'll be able to do those quickie checks, right?
Yeah, we can do a lot of checks. Yeah,
A lot
so I
of
think we
checks,
can do a lot of checks. We can, and I think a lot of it is, as I said, even more than my check. A lot of times, at least for young patients, a lot of times what the parents are noticing, what they're seeing. But yeah, we could definitely do checks. And
Now, because you talk about the venous system, okay, with these, is there, and you know, if they have the vascular malformation in other areas of their body, and they can be on anything from sirolimus to a lot of different medications, are they contraindicated, indicated for when there's glaucoma? Like, are there?
No, the question is, what else should we be using? So we actually I will often use systemic beta blocker sometimes because we think it has some effect. So I think there's a point here even about doing the surgery, going to Miami for the surgery. I think a lot of times the ophthalmologists will, even if they do a lot of complex glaucoma surgery, a lot of times we as the subspecialists will a lot of times be better able to deal with some of the challenging complications that come with dropping the pressure in somebody who has a vascular lesion. And again, what do we do? What are some little tricks? Some of it is using oral propranolol, so an oral beta blocker. We think sometimes it can constrict some of the blood vessels and lead to less leakage of fluid.
But aren't they also on the beta blocker?
Sometimes.
The timolol drops?
Sometimes, but an oral beta blocker sometimes does help, we think, maybe mitigate some of the risk that we take when we drop the pressure. There are certain other things we do with steroid, there's certain other things that we can do with the back of the eye, but the real goal is to be able to bring the pressure down in a gradual fashion, which is easier said than done.
True. Chelsea, the conference is October 10th and 11th in New York City. It's our annual VBF conference where we do the free consultations, free laser, free glaucoma check, free psychotherapy, free ultrasound, dental exam, and you can find it at birthmark.org. That's our website. Scroll down on the front and you'll see the big picture for the New York City conference and clinic. We're getting very close to maximum capacity, so if anyone is thinking about it, you should register today because we are really very close to being at our maximum because we're like the only one that does this in the world that offers free and glaucoma, free Sturge-Weber assessment, free dental, free ultrasound, free laser, free psychotherapy, and the bedazzling, that we have it all done. So, okay, so we're caught up with the questions now. I have one before, and again, all of you, please, this is your chance to ask Dr. Panarelli. We only have him for 21 minutes, so, we have one, okay. My son, port wine stain AVM, is on his nose, forehead, and around his eye. He's fairly farsighted and has strabismus. his doctor isn't concerned for glaucoma, but he still tests it. Would he be any more at risk? And again, this may be a ABM, CMABM?
It could be, but I would say that it sounds like they're doing a great job. It sounds like, they're doing the proper testing. I don't think you need to be any more concerned because there is strabismus. Strabismus is common, probably, even more common sometimes in children who are hyperopic for a variety of reasons. So I don't think there needs to be any concern. The big question sometimes often I get asked is how long do we need to be concerned for? Can we stop being concerned at a certain point in time? And I think the answer is I don't know. And so a lot of times I will still continue. I think it's still worth following, even if it's been a certain number of years, because I think it's hard to say that, are we ever in the clear zone? Are we ever free? And I don't know what the answer to that is. And I was wondering if that was where it was going. And I was going to say I don't know, but it sounds like they're doing a good job, but I don't think you need to be more concerned.
Dr. Kane, who has worked with VBF for a long time, has said that an individual with a port wine stain in the risk zone is never out of danger of developing glaucoma, no matter what their age is. And we have seen that. We've seen people present with seizures for the first time over 70, and people present with glaucoma later in life.
Yeah.
And in the port wine itself, in 70% of the people, is a progressive lesion, which would make sense if it's innervated, that what's going on behind the eye, the increased vascularity, would over time also.
Yeah, I think we don't know what's going on in the lesions themselves. And I think, as you were saying before, we don't know what's happening, as a child is, becoming an adolescent, as they turn into a young adult, as they become an adult. So we don't actually know, with all the changes in the human body, how much it can change, what is going on at the cellular level in these vascular lesions.
Thanks, Kiana. This is my birthday month, and I'm doing a fundraiser on Facebook, and she says I'm turning 31. I told you it's 39. Come on. Give me a break. Just kidding. Phenomenal. Now, I have a question. Can you grow out of glaucoma?
Unfortunately, no. Okay. So glaucoma is not a condition we can ever cure. And it's not a condition that you can grow out of. It is unfortunately a condition that requires, lifelong management. And
it's important to know.
We really, the adult form, we are often, I tell patients, we are trying to slow it down. I don't always ever expect to stop it. Children's a little bit different. In children, though, depending upon sort of what's going on, we can actually arrest the glaucoma. And we can, again, I'm never going to say we're home free, but we can really stop it. Versus more of the adult form, we're really just trying to get it moving at a slow enough rate that it doesn't cause any functional loss in a patient's lifetime.
I have another good question, which is, if there is a loss of vision due to the eye not being treated, maybe it hasn't been caught and there's a loss, can the loss be corrected, or is it once it's lost?
It's a great question. So, I was talking earlier, we have loss for two reasons often. One is the amblyopia, and one is the optic nerve damage. Children are often very resilient, and we know that in so many ways, and their tissue is very plastic. So I find that a lot of times the optic nerve damage, there can be a considerable amount, but there is always a good amount of functional vision. Now, any optic nerve damage, unfortunately, we cannot reverse. When the nerve is damaged, even though sometimes the nerve will get stretched out and it will become what we call cupped, and you can see the cupping reversed, the damage is the damage often. The bigger issue is really the amblyopia. So it's the brain learning how to use the vision in that eye. And so a lot of times if a child has the eye growing too large, it will not develop good vision initially. With patching and good treatment with pediatric ophthalmologists, that can be improved. So yes, if it's due to amblyopia, you can work harder at it, and you can often improve the vision in that eye.
And patching.
Patching. And that is really the more common vision loss in children with glaucoma. If there is vision loss due to just severe optic nerve damage, unfortunately, we cannot fix that. And so that is often why, as I was saying, for adolescents, young adults, we do often have to take those risks of surgery because that vision loss we cannot fix.
How young can a baby be and have a glaucoma check?
Right at birth. I mean, there are so many children. I actually think a lot of the process actually begins in utero. So a lot of children in general with primary congenital glaucoma, 80% are diagnosed within the first year of life, but about 20% are actually born with it. And so there are a lot of children And I actually think some have the process going on in utero, and then they grow out of it once they're born. In the first month or two of life, their drain matures, something happens. And so I've seen plenty of children who are born, one eye is larger than the other eye, they have a vascular lesion on that side, but everything sort of stabilizes itself. And I've had others where, yes, the eye does get bigger and it changes. So it is a complicated process, and it's hard because, again, you can be born with it, you can develop it in the first year of life, you can develop it late in the first decade. It doesn't follow a cookbook.
It's interesting because I have images of that the mom had sent me, and the baby's eye was 20% larger, the right eye, than the left eye. It was just bulging.
Yep.
And I looked at her ultrasound that she had in her last.
Could you see it there?
I could see it was larger, and I said, how come nobody picked it up if I could see it? So this would be very good, too, to collect this kind of data.
It is. Now the challenge is, I always tell parents, we have to be careful. I don't want to be overly aggressive for something
Right.
that had an effect, and that is a challenge. A lot of times when I'll see either a child, a young adult, I'll see some changes to the optic nerve. I don't know if that nerve is still changing, or if this nerve changed and it is now
Done.
stable.
Yeah.
And that is often one of the hard decisions to make when I see somebody for the first time is, am I dealing with a progressive condition, or was there an acute period where there was some changes to the optic nerve because of elevated pressure in the venous system, either in utero, right after birth? What is going on here? And that is where sometimes it does take some time. It does take some time, and it unfortunately is not as easy as just getting one evaluation. Now the trouble sometimes is you want to go see the specialist and have an answer. And unfortunately sometimes that's where I need to do my homework. Prepare beforehand, get a lot of information from your prior doctors. Pictures, as you, I think, always sort of ask for, those are very, very important, at least for the condition that I'm treating. I need to see if there's been changes to the eyes over time.
I have another question, and I might have asked you this before, which is, when the baby is born and they have the port wine and you do the checkup on them and you find out that they have the glaucoma, will you start them right then and there on the drops, or will they be because you want to prevent any damage that can't be reversed?
Good question. So, if a child, and give me a ballpark age here.
3 weeks.
Okay, yeah, so very young child, born with it. A lot of times in those situations, the eye will be hazy. And so that's the first giveaway. That eye is hazy, that eye is getting big. Drops in that situation, we sometimes will only do merely to make some of that haziness go away, to maybe make our surgery a little bit easier, depending upon what our surgical approach is. Sometimes we'll go in the eye to try to open the drain, and sometimes we'll go from the outside. Having trained in Miami, I always go from the outside, so it doesn't really matter for me what's going on. We'll start the drops because I think it's also a little comforting that we're treating it, we're doing something. But really, we're trying to get to that OR as quickly as we can to clear up the haziness and to stop that eye from expanding. Because if that eye continues to expand, you can get breaks in the front of the eye, and those breaks can lead to swelling and scarring, and that can ultimately lead to amblyopia. That's irreversible, yeah. So there's different things that can be going on, but in general, we're starting the medication to help clear the view for surgery, and a lot of times just to transiently lower the pressure, but we know that we need to do something surgically at that point in time.
Thank you for that. Another question, I had shared with you quite a few photos that I've been collecting over the years where, we all know the rule of thumb is newborns aren't supposed to be out in the sun for the first 6 months of life. Mainly, they're not supposed to be exposed to direct sun. But I see so many pictures of the moms with the little ones under 1, and you can tell they're outside, and the eye pinches where the birthmark is, and I say, oh, does the baby have glaucoma? Oh, no, everything's normal. I suspect it's like an early alert. What happens with the eye that has glaucoma when it is in the sun?
You pick up stuff. As I said, I feel like, you can do what I do. Okay, so the classic teaching when you're trying to diagnose a child with glaucoma, we look for this classic triad of 3 sort of signs and symptoms: tearing, spasming of the eyelid, and photophobia, fear of light. Why do they get this? When the pressure in the eye goes up, you can get fluid in the cornea, and fluid can get underneath the superficial layer, underneath the epithelium. And that causes kids to be very photosensitive, and causes them to squint a little bit, and they get blepharospasm, which is just sort of closure of the eye. So, and they will often tear on that side. Now, you can't always take that to the bank that they're going to have the classic triad. But I think what you're maybe noticing is these children having elevated pressures, having some fluid under the superficial layer, and yes, it is worse with sunlight and sun exposure. And so they'll be a little bit photophobic, and they may be squinting a little bit and trying to close the eye as a protective mechanism.
Now, I
100%.
understand the tearing and the photophobia, and the third part of the triad
Is blepharospasm, so
So
closure.
what does that
They're
look
trying
like?
to spasm. They're trying to close their eye.
Oh,
They're
the
spasming.
baby
Yeah, they're
is.
often
Okay.
closing there. So they're having so much trouble with the light. A lot of times they are kind of spasming and trying to
Okay.
close the eye.
Okay.
So yeah.
I was thinking you meant like an actual spasm like this, but
No,
it's
more
more
of a
like
full closure.
more
yeah.
like their protective mechanism
Correct.
is to close
I think
that
what you're
eye.
seeing probably is a protective mechanism.
Yeah.
I think that pinching
But
is.
that's early then, because they're saying no glaucoma.
Again, hard to say that definitively that there is no
Right.
glaucoma at that point in time.
Right,
You know, again,
right.
you can get a pressure reading in the office that can look okay one day of the week, and then 2 weeks later, as we were talking with somebody else who was on the broadcast here, where the pressure was out of nowhere, the pressure's 34 to 40.
Right.
So it's hard to take that and say that just because somebody said they didn't see any at that moment in time.
Mm-hmm.
I mean, I've had plenty of cases where I didn't see it the first visit, and then I said, hey, come back, and all of a sudden we pick things up. Some things aren't readily apparent right away, and so it's hard to know. And that's where, again, it takes the whole team. It takes the parents, it takes the pediatrician, the pediatric ophthalmologist, the glaucoma specialist. I will happily get on the phone and call other members of the team and say, hey, what did you see at that exam? Did you note anything in your notes? What did you see? Because sometimes I don't see it when I see them in the office.
And, as we wrap up, we have one more question here. Thanks for the previous answer. We live in Europe, therefore, is it possible to get a second opinion online with you? We have an MRI, fundus photos, ultrasounds, medical descriptions in English. After a shunt surgery, how long is the follow-up? So can they get...
Happy to take a look. I'm happy to take a look at anything. You can email me.
And we have him on our website as an expert, so you can look for his name, Dr. Panarelli,
So,
on our website.
happy to email back and forth, and happy to even do a televisit, and we could talk more. Shunt surgery varies. A lot of times I tell patients that I would like to have them here for several weeks afterwards, so that I can make sure everything is good. A lot of times I will call an ophthalmologist or talk with somebody either that I know or the primary ophthalmologist, and we all work together. I think a lot of times for the more complicated cases, we're all humble. We all work together and do what is ultimately what's best for the patient. So happy to offer an opinion. Happy to at least review and look at everything and just talk. We can see what's going on. Sometimes, honestly, like you said, Linda, with pictures, I can often see a lot even just from an external photo of the eye in terms of being
You
like,
can
okay,
see the cloudiness.
I can see
or
if you
or the,
with enough looking in different gazes, I can often see enough to be like, okay, I see what they're saying, why this might be more challenging, or hey, we can do something. Let's think about this. Let's ask your doctor about that. Happy to, and I think that's one of the beautiful things about being here or something like this is that if I can help one person, that make me so happy.
Okay, so Kiana, you're on. I'm going to have Dr. Panarelli say his email so you can put it in the chat. So if you could say
So
your
you
email.
can either do joepanarelli@gmail.com or joseph.panarelli@nyulangone.org. Either one, I am perfectly happy, and I answer both.
Okay.
I am pretty fanatic with checking.
So Joseph Panarelli at gmail.com?
Just Joe Panarelli.
Oh, Joe Panarelli, all one word. So you can put that in, Kiana, Joe Panarelli at gmail.com. That's probably easier.
Yeah, probably easier.
What a phenomenal session. Now, Lorden, I see that you just joined us, and we are finishing up our first VBF Facebook Live on pediatric glaucoma and all things of the orbit. Before we log off, did you have a question for Dr. Panarelli? Because we're wrapping up here for our 1 hour session. And I know, I believe she might even be at our conference, so she just joined. Oh, thank you, Kiana. Yes,
Perfect.
Joe Panarelli at gmail.com. Great job. Thank you so much for that. So we've got like another minute if anyone has any more questions. Phenomenal session. This session is available. You can go back into forward into infinity to see it. Yes, she's saying thank you for the subject. They stay on our VBF YouTube channel, It will stay on our Facebook page on Facebook for 30 days, then they automatically take them down now, but we keep them. As of tomorrow, it'll be on our YouTube channel, so if you go to birthmark.org, down to the bottom, and you see the YouTube icon, and click on it, they're in order of the latest to the newest. So Dr. Panarelli's will be the first one on there. The last one was with Leslie Graff, our child life specialist. So thank you, great session. Thank you
Wonderful meeting. I
everyone
really appreciate
for
it.
joining in, and, sorry, I guess, hold on, let me just cancel that so I'm not being rude. Thank you very much, and
Thank you for having me. It was great. I love all the engagement
excited to have
the
you
work you
join
do.
us at the Super Clinic and conference, and trust me, we have a lot of people
I'm
signed up to
excited.
see you. So, thank you all. Oops, sorry, just trying to log off.